All right, so let's go ahead and pick up with the hepatitis viruses. I know we're supposed to have an exam this Friday, but would y'all be real mad if we did it the Friday after Thanksgiving, or would that be all right? Jessica's ruining it for everybody. No, I'm just kidding. Is that okay? The Friday after Thanksgiving? Friday after Thanksgiving? Friday after Thanksgiving?
Birthday.
Girl, I had an astronomy exam on my 21st birthday. I have no sympathy. Happy birthday. I'll make it easy for you. See, there you go. But you were still going to come to class anyway, right?
Yeah.
Oh, okay. 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 I don't know what the date is. Friday, December 1st.
Friday, December 1st?
Mm-hmm. Friday, December 1st.
And then we have a final on the 30th.
And the final will be on the regular final day. Yeah. So there probably won't be a ton of new information between then and because you'll have to do your presentation and stuff. So.
Is our final
Oh, it is cumulative.
I was like, never said that word.
Comprehensive.
Okay.
Yes. And so as a forewarning, we're going to play the doctor game. And so one of you is going to be the patient. So kind of be thinking about a case you might want to develop. We're going to randomly pick a patient in a little bit. Okay? But let's finish with hepatitis. So we talked about hepatitis A on Wednesday because we got Friday off last week. How fun. So today is hepatitis B is where we're going to start. We go in alphabetical order. So hepatitis B is a different viral family than hepatitis A. So remember, hepatitis A is one of the picornaviruses, right? So it's a single-stranded RNA virus. Hepatitis B belongs to its own family that we haven't talked about yet, called the hepatinoviruses. So these are enveloped DNA viruses. And we're going to see in just a second that they have kind of a weird type of replication for a DNA virus. And hopefully we'll be able to pick out which other type of viral family has a similar type of replication. So sometimes this is called serum hepatitis. It is often found as a bloodborne infection. So this, if you work in a clinical setting, you almost certainly were encouraged or required to get vaccinated against hepatitis B. It can also be sexually transmitted. Unlike hepatitis A, hepatitis B can establish a chronic infection, and it can be oncogenic. It can lead to liver cancer. Okay, so I told you it has kind of a weird replication. It's unique among DNA viruses. And so it actually will go into the nucleus, which is normal for a DNA virus. It will transcribe its DNA into RNA, also normal for a DNA virus. Now, normally what a DNA virus would do is inside the nucleus, it would also replicate its own DNA, right? So that when it goes to assemble the virions, it will be able to package its DNA into the virion. But what hepatitis A does differently is out in the cytoplasm, it uses the RNA that it has transcribed as a template for DNA synthesis. So it uses reverse transcriptase to read RNA into DNA. What other type or family of viruses read RNA and make DNA? Retroviruses. Very good. Like HIV. So it's a weird strategy for a DNA virus. It's unique for a DNA virus, but it's not unheard of to use reverse transcriptase. One of the other cool things about hepatitis B, we'll get to in just a second. For an enveloped virus, it's pretty stable, right, which means it's more transmissible. But the other cool thing it does is it can evade the immune system by producing what are called antigenic decoys. So it will basically, and it shows them in this image down here in the bottom right, it will basically fling out pieces of envelope that have viral proteins in them to occupy the immune system, while the actual viral particles can go and continue to cause infection. And they will release far more of these decoys than they will of actual viral particles. And the genome, not unique for a DNA virus, can integrate into our chromosome, which is partly why it can be associated with causing cancer. But for me, I think the two really important features of hepatitis B are the fact that it does reverse transcription and those antigenic decoys. Those are the really cool and unique things that it can do. It can be found in a lot of different bodily fluids. And generally what we see in the majority of patients is the virus will get into the liver, it replicates, people have an acute type of infection where their cell-mediated immunity, their T cells, go in, clear out the infected cells, and we're fine. You'll have jaundice, you'll have the release of liver enzymes, but again, in most patients it can clear. In patients who have a limited cell-mediated immune response, for some reason, maybe their T cell response isn't as robust as we'd like it to be, they may develop far more mild symptoms, but they also can develop that chronic infection. And when you have patients that have a chronic infection, the two things that we can look for here are the development of liver cancer and cirrhosis of the liver. Right? The liver is great. It has really strong regenerative capabilities. It's one of the few organs that you can donate a part of while you're still alive and give it to someone else. It takes a lot of abuse. Some people abuse it more than others. But this type of infection, that cirrhosis, that's not reversible. We don't fix that. So that permanent liver damage is really dangerous. The other thing that we'll point out right here, and we'll talk about more in just a minute, is when you have or superinfection with something called delta agent. Delta agent is hepatitis D. And so in just a minute, we'll talk more about that and the more aggressive, fulminant means kind of like a more aggressive, dangerous type of infection. So we'll talk about that in just a minute. Again, the cell-mediated immunity, it's an immunopathogenesis. It's what's causing a lot of the symptoms, the jaundice, the release of liver enzymes, but it's also critically important for resolution of the infection. What we can also sometimes see in patients who have hepatitis B, especially because of those antigenic decoys, those can tie up the antibody response. And you get the formation of immune complexes, these clusters or clumps of antigen and antibody that are prone to clogging up places, causing inflammation. And again, this is where you can have all sorts of transmission, mother's milk, vaginal secretions, blood, semen, saliva. Often in healthcare settings, you might have it through a needle stick injury if you have a patient that has the infection. IV drug users, people who engage in unprotected sex with multiple partners tend to have higher incidence of hepatitis B as well. Okay. With that decreased T cell response, you're going to be really cautious looking at those patients that may have defects in cell-mediated immunity. That could include patients undergoing chemotherapy. That could include your HIV patients that may be at more risk for developing chronic illness. Antibody is also helpful in protecting against infection. So we need to have the antibody as more of the protection against infection, because antibody can bind to the viral particles and neutralize them, prevent them from binding to the host cell, but, right, it can also form those immune complexes. So children generally have less severe symptoms. Why would that be?
Not as good immune system.
They don't have as good of an immune system. Children have a weaker immune system. So in this case, if they get infected, they would have less severe symptoms. But the consequences of that are shown here. They're less able to clear the infection, and about 90% of infected infants become chronic carriers. It can cause swelling and necrosis of the liver. If the infection can resolve before permanent damage, because the liver regenerates, you can have regeneration of those areas that have been damaged. But a fulminant, like a really aggressive, a chronic, or a co-infection with delta agent, hepatitis D, will lead to that permanent damage, the cirrhosis. And once a patient has cirrhosis, what is the only real treatment? A liver transplant. Yep, very good. Liver transplant. Okay. And again, just like we talked about last week when we were talking about curing HIV using a bone marrow transplant, right? The challenge is you have to find somebody who's a compatible donor. You have to find someone who's willing to let you take part of their liver, and they're compatible with you. And that can be difficult when we talk about minority patients or patients who are mixed race, because it tends to be easier to find a match. If you can't find a familial match, it tends to be easier to find a match, somebody with the same racial or ethnic background as you. And so if you have a patient who has, an ethnic or racial minority background, or they are mixed race, it can be very difficult to find a non-familial donor. Okay, so hepatitis B is pretty common. It's estimated that there are somewhere along the lines of 850,000 people chronically infected with hepatitis B in the US, over 250 million people worldwide. And this number is, again, worldwide, we're looking at approximately 15% of the population being infected with hepatitis B at birth or during early childhood. And so the prevalence, you can see in red represents the highest prevalence. In yellow is an intermediate prevalence. In green is low prevalence. And the areas where we have the dark spot, that's the highest incidence of the cancer that's associated with hepatitis B, the primary hepatocellular carcinoma. So our most at-risk groups, people from endemic regions, China, parts of Africa, Alaska, the Pacific Islands. Mothers, yes.
On the previous slide, the high incidence of prevalence in the northern portion of North America, is that due to low population numbers? So like the population there's less people there, so those that have it, would that increase the percentage?
So it tends to be seen at higher levels in the US and Canada in indigenous populations, and so there's a much higher indigenous population in those areas, and so that's why. Often it's a lack of resources and healthcare infrastructure to prevent the infection. Yeah. And that's a really good question. You have to think about those things. Where are your patients coming from? What is their background? For some infections, yes, particular racial or ethnic backgrounds might be more sensitive to getting the infection. But for other infections, everybody is equally likely to develop the infection, but it's the access to resources to prevent. It's the access to the education to learn about how to prevent. That can lead to higher incidence in some places. So intravenous drug users, people with multiple sex partners, hemophiliacs, and other patients requiring blood and blood product treatments. This all should sound very familiar, very similar risk factors to HIV. And we'll see the same thing when we talk about hepatitis C. And so when you have patients that have HIV, you should probably screen them for these viruses. If you have patients with these viruses, you should probably also screen them for HIV. The risk factors are so similar. Healthcare personnel who have contact with blood. I hate the term, but that's the term the textbook uses. If you work with people who have cognitive disabilities, again, it's because of sometimes there's aggression in the patients, or there's a lack of maybe good personal hygiene in the patients, that if the patients are infected, the workers and other residents may be likely to get infected. It has nothing to do with the fact that like having a cognitive disability does not make you more prone to developing the infection. And sometimes people are mistreated in those types of environments. You may have all heard of the case of, there was a woman who was in a persistent vegetative coma that got pregnant. Okay, that's not supposed to happen. So you have to really be cognizant of all of those issues. And then again, hemodialysis in patients who are blood and organ transplants. Most common symptoms, patients may develop fever, rash, arthritis, but really commonly right upper quadrant pain. Your liver hurts. It hurts. Okay, you're having viral damage to the liver. You're having immunopathogenesis. Your immune cells are attacking the liver. You may have nausea, loss of appetite, tiredness, dark urine, and jaundice because of the release of liver enzymes, the bile production. Now, the majority of patients, hepatitis B, 90% will resolve the infection on their own. 1% will develop a very aggressive fulminant form that that basically means it could be like immediately fatal. 9% or so will develop what we call chronic. 50% of those will resolve it. Some of them will be asymptomatic. Some of them will have persistent hepatitis, and some of them will have active hepatitis. And the active is where we worry about cirrhosis and carcinoma. It's a really rare progression of the disease, but it is a possible progression of the disease, especially in your patients who have defects in T-cell mediated immunity. So it's definitely something to look out for. Yes.
This side is like a common one.
Right here is most common. 90% will resolve the infection.
What about this one, the one you say dark urine and that's-
This,
Yeah, that one.
this is the symptoms that people will develop, the most common symptoms. Yeah. Yeah, good question. So these are the most common symptoms, and then this is the most common outcome of infection: resolution, clearance. Okay, so 5 to 10% of patients will develop chronic infection, and about 1/3 of those will have that chronic active form where the virus is continuing to replicate, you're continuing to have tissue destruction, you get the eventual development of cirrhosis and potentially the development of the primary hepatocellular carcinoma. Now, this is one of the important statistics. About 80% of that type of cancer, that primary hepatocellular carcinoma, are directly attributed to a chronic hepatitis B infection. We don't see a ton of viruses that have that high of an association with causing cancer. Do you guys remember what the other one is that's really highly associated with cancer? HPV. Yeah, remember something like 99% of cervical cancers, 70% of oropharyngeal, 70% of like penile and anal cancers are associated with HPV. So 80% of this type of liver cancer associated with hepatitis B. And it is usually fatal. In terms of, is this the most common type of cancer? No, absolutely not. But it is one of the more common types of fatal cancers. It's kind of like pancreatic cancer. They often don't know, the patient doesn't know they've developed cancer until they've developed cancer in an organ that more directly causes some type of negative symptom. Like, oh, I can't breathe. I have lung cancer. My bones hurt. I have bone cancer. Right? Generalized abdominal pain you don't usually think is cancer. So it tends to progress before it's diagnosed. So we can diagnose it based on symptoms and liver enzymes. Again, anytime a patient comes in and they have jaundice, so their skin tone may look yellow, or if you can't tell that their skin tone is yellow because different skin tones look different, they're whites of their eyes. That's usually going to be easier to diagnose. Serology can describe the course of infection. So what type of antibody do we look for first? IgM, right? That indicates an early infection, and then we would see more IgG. Very good. If you know that you have a patient with exposure, you can do passive immunization. This can also be done for newborns. They actually will now vaccinate newborns at birth. They will literally we're going to do things to your child. Are you okay with X, Y, and Z? And one of those is the hepatitis B vaccine, at birth. Treatment with polymerase inhibitors, right? We have that weird reverse transcriptase, that unique polymerase that converts RNA to DNA. So that unique target provides an opportunity. Also, nucleoside analogs can work. And of course, as I mentioned, there is a vaccine. I imagine that most of you have probably been vaccinated against hepatitis B. They wouldn't let me live in the dorms until I did, so I know I had mine a while ago, and I also worked in a clinical setting, so I had to have it done. So if you haven't had it done yet and you're planning to work in a clinical setting, just know this is probably going to be something they're going to sign you up for.
Once you've developed the chronic infection, if you don't have the vaccine, can you get it to help prevent?
So in that case, what they might do instead is do the passive immunization, maybe, to help give you preformed antibodies to help prevent the virus from spreading. The challenge is you often develop the chronic because you don't have good T cell counts. So it can be hard to boost the T cell counts. So they probably would give you a combination therapy. And I mean, it can't hurt to be vaccinated as well. Other questions about hepatitis B? This is probably going to be the second most common. You might not even see patients that have hepatitis A because they'll probably resolve it on their own. Hepatitis B might be the most common hepatitis you would see. I'm going to go in reverse alphabetical order. Yes.
How about for the at-home births? I know people have to go to the hospital, right, after a couple of days.
You don't have to.
You don't have to?
Mm-mm.
So,
No, there's a whole subset of people that will do birth at home, and there's even a really weird subset of them that are they don't want their kids to get social security numbers, birth certificates, nothing. So they stay really off the grid. They can't force you to have medical treatment. But if for example you do choose to have birth at home, either by yourself or attended by a midwife or a doula, when you take the child in, if you choose to do so and take the child in, they would give it to you then. Yeah. Usually at birth what they do is a vitamin K shot to prevent bleeding, because children don't have really good clotting factors right at birth. They'll do an antibiotic ointment in the eye, and we've talked about why, in case the mother has some sort of active genital infection, and they'll do the hepatitis B vaccine. So babies are crying, and then they're like pop, 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 and then they have goopy eyes for a little while because they put that ointment in them. But yeah, if you gave birth at home or outside of a hospital setting, you could always do that during the first pediatrician visit, which they would do. Mine was at 4 days after birth, so they'll do it really early. Other questions about hepatitis B? And then they'll do the follow-up vaccines, I think at 2 months, and then maybe at a year. So most, children that are not infants are protected. Yeah. But this is a new for me because I'm old, mid-90s, so they didn't used to vaccinate infants. That's why I had to get mine when I was older. Okay, so I lied about alphabetical order. We're going to talk about D for just a second. So hopefully I did skip a whole letter in the alphabet. Hepatitis D is the one that they sometimes call Delta agent. So viral biology is really weird. And Dr. Tao and I have talked about developing a virology course just because viruses are so cool and how weird viral biology is. So hepatitis D is not really a virus. It can't replicate on its own. So when it infects a cell, if it's the only virus there, it can't do anything. Hepatitis D can only replicate in the presence of hepatitis B. And so they call it a subviral satellite. It's almost like a viral parasite. So again, viruses are weird, sorry. So it can only be transmitted with hepatitis B, or you can get it as a super infection. Like after you've gotten hepatitis B, if you're exposed again, you can get the Delta agent or hepatitis D. So that's what, I don't know how your Greek is, but that's what that little symbol is Delta. Okay. So when you have co-infection, when you have the co-infection with the Delta agent, with the hepatitis D, you're more likely to see more serious consequences. If it's just hepatitis B by itself, remember like 90% of patients are going to clear it. When it's both, you're more likely to have that fulminant hepatitis, the really dangerous type of hepatitis that can progress to being fatal very quickly. You're also more likely to develop cirrhosis or chronic infection. And there's really nothing you can do to prevent it except for prevent hepatitis B infection. So if you can prevent yourself from being infected with hepatitis B through vaccination and through these other practices like not sharing needles, careful with unprotected sex, like those types of things, then you're going to be fine. But when you have a patient that has hepatitis B, that's something you worry about, the co or super infection with D. So let's pause and play a little game. I feel like what's that movie, Saw, right? And it's that little, I've never even seen the movies because I get so grossed out by blood and gore and stuff, but I know it's like a creepy little puppet that's like, do you want to play a game? So I'm the creepy puppet. Let's play a game. It is random. Let's do it. Let's do random. Who is going to be my patient? Okay, let's see here. Where's my data? Sort by column B. Okay. Simran, you are my patient. Donna, you're my timer. Jessica, you're the accountant. Emily, you're the senior resident. And Asima, you are the attending. So as a reminder, timer, that's pretty easy. Accountant, you make sure we don't go broke. I'll pull up the prices in just a minute. The senior resident, you make sure everybody gets a chance to contribute their thoughts, but my attending, you make the final call. You make the final call. You're the boss. You're the attending. You get to be the boss. All right. So, Simran, do you have an idea? Are you ready? Okay. All right. So, Simran's our patient. So we want to give her our full attention. So as a reminder, she will tell us who she is and what symptoms she's feeling. And you will have 5 minutes to ask her questions until you have to decide what tests you want to run. So timer, you ready? All right, 5 minutes and counting down. So not yet. Who are you? And then we'll count down. Okay, that's it? Okay, 5 minutes.
Have you had a cough or any respiratory symptoms?
Remember, she can sue you for malpractice, so you want to make sure you ask all the questions.
Is your fever there all the time or is it coming back?
Okay, time's up. So now all the physicians, you have 2 minutes to discuss among yourselves what tests you want to order for what infection.
No, I don't think so. She said about Hepatitis But they look at that.
No, I don't know about obviously the test. Oh, do we need to know what test? Nucleic acid test? Just
Yes, doctor, you have to tell what tests. Yeah, Western blot ELISA would be like a similar thing, looking like a protein-based test. That'd be fine.
Because like it's.
No pressure. She's gonna die. I don't know.
Oh.
I'm just kidding. Y'all killed Simran. Sorry.
So yeah, like ELISA or Western blot for, I guess, LPS. So for rickettsia. That's it. I mean,
What kind of test,
You could do an ELISA or a Western.
I mean, that's.
An ELISA would be more sensitive if you were trying to look at the ratios. Yeah. Yeah. All right, time's up. So what tests are you ordering for which infections? ELISA for rickettsia? Which one? There's lots of rickettsia. Rocky Mountain spotted fever. Okay.
Wait, where are the Rocky Mountains?
Colorado.
No.
But it's not geographically limited. You can have Rocky Mountain spotted fever in other parts. It's just called Rocky Mountain spotted fever. Are you wanting to do one of the spotted fever? You think she has spotted fever? Okay. Simran, do you have spotted fever? Uh-oh. Now she's upset. She's had to come back. Your test was wrong. You have 1 minute to decide what other test you might want to run, or she's going to sue you for malpractice. Or she's going to die. I don't know yet. Maybe both. You have 1 minute. It's her follow-up visit. You can ask more questions.
Do you have a headache?
I need like a Jeopardy playlist, like the, Final Jeopardy. How much time left do we have? Oh, okay. That's it. What test are you going to order? You can order one more test. And you only get 30 seconds to pick or she's going to sue you. Did you say sue me? Someone's like, yes, you paid my tuition this semester. Okay, final call, last test. All right, that's it. Donna's got your timer, so you're done. Any test you're gonna pick?
And Lyme disease. And Lyme disease.
For what and what? I heard Lyme disease. I didn't hear the second one. For which one? You're gonna do an ELISA for you think she has Hanta? Okay. So you're gonna test her for hantavirus and Lyme disease. Okay. So remember, you have to note that down. What kind of test are you doing for the bunya? Nucleic acid? And for the Lyme disease? ELISA? Do you have either one of those infections? Yeah.
There you go.
I knew right away. She said she had a rash that was a circle rash, like a bullseye.
No, she
She
said
said
she
she's
said
also a
circle,
bullseye.
just not a bullseye.
Oh, a circle. Well, she said circle.
I knew it, the white-tailed
White-tailed deer. Yep. The circle rash is hallmark of Lyme disease. Rocky Mountain spotted fever is going to be a full body rash. full body rash with Rocky Mountain spotted fever. So she had Lyme disease. Okay, you didn't kill her. She's not going to sue you for malpractice. You figured it out. Now, what are you going to do for her? She has Lyme disease. Poor thing. What are you going to do? Treatment. That's good. What kind of treatment? What kind of treatment do we prescribe for Lyme disease?
If she wants to go to the holistic route, there's been studies about injecting yourself with bee venom.
With bee venom, she does not want to go holistic. She does want something, though, because Lyme disease is not fun. You give her some antibiotics. Yep. Really commonly for Lyme disease is going to be doxycycline. There's not a lot of resistance in Lyme disease, but it's also a very slow-growing infection. So you're probably going to want to give her 6 months of doxycycline.
What about penicillin? Is that gonna work the same?
It could, but doxycycline's better. They have spirochetes, especially Borrelia, has very little peptidoglycan. So penicillin isn't the best. Doxycycline is better. That's the drug of choice for Lyme disease.
We saved her.
You saved her. Yes. She's not going to sue you. Ha ha ha. All right. Cool. Let's wrap up the hepatitis viruses, and then we'll call it a day until Wednesday. So, your hepatitis viruses, pretty much anytime somebody tells me it's a tick-borne illness, I'm like, it's Lyme disease. It's Lyme disease. Lyme disease. Especially, I don't know if she said where she was hiking, but if she was on the East Coast, it's always Lyme disease. One of these days it'd be fun if somebody did like the meat allergy. There's a tick-borne red meat allergy. Yeah. I'll do that next semester. Next time I teach this class, I'm going to do that as my case. I just can't eat burgers anymore, man. Make me sick. It's a real thing. You know about it, right, Dr. Turlock?
Yeah, one of my good friends, his wife had it.
Ah, see?
Can only eat
Like chicken
lamb.
and fish.
Can
Yeah.
only eat lamb.
Oh.
Luckily, her parents own her sheep.
Oh, okay.
Oh, it's good.
But other than that, yeah, the red meat allergy.
Biggest fear of my life.
See, for me, I'm like, whatever. I don't care. But, yeah, I'm like 90% vegetarian. Every once in a while, I'll go on a wild hair. So I can cut it if I had to. Hepatitis C, so kind of like bounced around the alphabet a little bit, is the last hepatitis virus we'll talk about. So hepatitis C is a member of the Flaviviridae. So it's related to like yellow fever and some of those other arthropod-borne infections we talked about. But it is not an arbovirus because it is not transmitted by arthropods. But like the other members of the Flaviviridae, it is enveloped, positive sense strand, RNA virus, and it is the primary cause of non-A, non-B hepatitis. And that might seem like a silly distinction, but before the hepatitis C virus was characterized, that's literally what people had. They had hepatitis, but it wasn't A and it wasn't B, so it was non-A, non-B hepatitis. We now know it could be E or G, not F, because there is no F, but hepatitis C is the most common. 170 million chronic cases worldwide, 3 million chronic cases estimated in the US, about 17,000 deaths per year. The transmission is similar to hepatitis B, to HIV. It's a bloodborne, sexually transmitted infection. We tend to see high levels of hepatitis C in the IV drug user community. Okay, if they share needles. So again, these ideas of like a needle exchange program is not because we're trying to promote drug use, it's because we're trying to prevent transmission of diseases like HIV and especially hepatitis C. Hepatitis B, like there's a vaccine, so it's not as big of a concern, but hepatitis C, HIV, no vaccine. So that's why the clean needle exchange, condom distribution are really important. It infects only humans and chimpanzees, so it's kind of a limited host range. The majority of patients in this case with hepatitis C, unlike hepatitis B, 70% of patients will develop a chronic persistent infection. Only about 15% will recover and clear the infection on their own. 15% will develop rapid onset cirrhosis and liver destruction. The majority of your patients are going to develop a chronic infection. Many of them may be asymptomatic for a while. It's like HIV, you never know. How long? Right. Eventually, the patients who have persistent infections will generally develop chronic hepatitis. The majority of them will develop cirrhosis, but you can also see liver failure and that same hepatocellular carcinoma, so liver cancer. Diagnosis would be based on ELISA or reverse transcription PCR. You're looking for the RNA, the genetic material. It would then be confirmed by a Western blot. You can use interferon, other nucleoside analogs, polymerase inhibitors. Hepatitis G, we don't really talk about because we don't know a ton about it. It seems to look a lot like hepatitis C in terms of its genetics. It's a flavivirus, but it's unknown really how much disease it truly causes. We know it exists. They have found it in patients, but how associated with disease is it? Is it as severe as hepatitis C? Maybe not. These are things that we're still learning about. Like I said, prior to the discovery of hepatitis C, you either had A or B or something. Didn't know what it was. So as we learn more and more about these viruses, as we do more and more genetic analysis, we can start to tease apart what viral infection is really there. But when they're similar viruses in similar families, similar genetically, really sequencing is one of the only ways to tease them apart. So as that technology gets better, we get better and better at separating different infections. So we'll pick up on Wednesday with prions. Sorry, I know I told you we might talk about prions. We observed a class this morning together, so I told her, oh, prions, but then I was like, oh, I forgot, we're still doing hepatitis. So prions for sure, and the beginnings of fungi on Wednesday. And I don't promise that I won't do fungal puns.
And our exam's officially moved.
Exam December 1st.
We still have on Friday then.
Yes.
No.
No.
I'll post some videos. No, the reason that I had to move the exam is because I got invited to go to a conference.
Oh, okay.
And I tried like really hard to get a flight like a little bit later, but I couldn't.